Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Hello, everyone. Thank you for listening in to this episode that is produced in collaboration with the American College of Gastroenterology's Patient Care Committee. This exciting and informative episode today will give us the inside scoop on the recently released ACG guideline on gastroparesis. Now, gastroparesis is a disease that affects the stomach. And basically, if you have this condition, your stomach is partially paralyzed and can't empty itself in a normal way. But we'll learn more from our expert guests in just a little bit. Now, ACG publishes a variety of guidelines that serve as evidence-based guidance for healthcare providers to help them diagnose, treat, and manage patients with various gastrointestinal symptoms and conditions such as gastroparesis. Think of a guideline as a best practice playbook to deliver quality patient care. So what do patients need to know about the new gastroparesis guideline, and why should patients care about this guideline? Well, that's why I've asked two leading gastroenterologists to join us today. Dr. Michael Camilleri of the Mayo Clinic in Rochester, Minnesota, and Dr. Linda Nguyen of Stanford University in California are among the most respected and accomplished gastroenterologists in the country. They are also the key authors of this new ACG gastroparesis guideline that was published just last month in the American Journal of Gastroenterology. Welcome, Dr. Camilleri and Dr. Nguyen. So nice of you to join us today.
Thank you.
Thank you.
We're so excited. So before we get into the guideline, let's just give our listeners today a little lay of the land on what gastroparesis is, who is affected, the prevalence and demographics.
Well, gastroparesis is really a combination of the symptoms that occur when the stomach does not empty, like nausea and fullness after the meal, sometimes vomiting, and abdominal discomfort, upper abdominal discomfort, and bloating. And this is occurring in the context of the stomach not emptying food at a normal rate. And it's important that the patient does not have any obstruction in the lower part of the stomach that may occur, for instance, from an ulcer of the stomach. So those are the three main elements of gastroparesis: the symptoms, the slow gastric emptying, particularly of solid food, and the absence of a mechanical obstruction that would be impeding the emptying from the stomach.
Okay. Now, who is typically affected by this?
Predominantly women. And actually, Dr. Camilleri published a recent paper on, kind of a review of the prevalence of gastroparesis. And most commonly, you see this in individuals who've been affected with diabetes, whether it's diabetic, post-surgical, or idiopathic gastroparesis. Women tend to be affected more than twice as men.
Oh, wow. Now, is this considered a rare disease, or is it becoming a little more common, or are we just not diagnosing people in a quick manner because they don't know what this is?
This is a really important question, and it all kind of depends upon what criteria are used for the diagnosis. So let me give you an example of what's been published.
Okay.
Sometimes if the diagnosis is based on those 3 points that I made, the symptoms, the slow stomach emptying, and the absence of obstruction, one would come to the conclusion that it's a rather rare disease. In fact, the prevalence in the United States may be as low as, maybe 100 persons per 100,000. So that would be a relatively rare disease. But on the other hand, if the stomach emptying is not tested with the right diagnostic test, and we use other criteria, for example, the patient might come for an endoscopy and we find food in the stomach. Now, sometimes that is equated with gastroparesis, but it turns out it's not a specific finding. It may be found even in healthy people sometimes. Or a study that was actually done here at Mayo Clinic had shown that if you found a patient who had food in the stomach after an overnight fast, the likelihood that they're actually going to have objectively delayed stomach emptying on the diagnostic test was relatively low. And then the third category is patients who have just the symptoms. Now, if you were to take that group, then it would be relatively common in the community. But then this is where there is this overlap with other symptoms, like functional dyspepsia or a stomach disorder of function that isn't quite a paralysis of the stomach. Paresis, of course, in the word gastroparesis means paralysis of the stomach. So it does depend upon how you define the condition. In general, however, I would say that, for instance, among type 1 diabetics, which Dr. Nguyen mentioned earlier, it's estimated that only about 3 to 5% of type 1 diabetics actually have gastroparesis. So it's a relatively, in the full-blown picture, with the full criteria, it's a relatively uncommon condition.
Now, what are the symptoms? Like, what would make a patient, start asking their doctor about, do I have gastroparesis? What are some of the symptoms that they might feel?
Yeah. I mean, the most common ones are nausea and vomiting, and followed by early satiety. And there's some mild differences in patients who have diabetic versus idiopathic gastroparesis, but the nausea, vomiting, early satiety, and fullness are kind of the cardinal symptoms. There's a lot of debate about the pain part. And I'm sure you've noticed, or at least I noticed, Dr. Camilleri said abdominal discomfort, and he stayed away from the use of the word pain, because there's debate whether or not upper abdominal pain is truly gastroparesis or something else. And part of that something else is this overlap with the functional dyspepsia. So, the definition of gastroparesis requires these symptoms, but also that delay in gastric emptying. So, depending on where you look, you could argue that there may be an underdiagnosis of gastroparesis, because oftentimes the gastric emptying is not performed, or is performed incorrectly. And so we do not truly know the prevalence and how common gastroparesis is in the US or worldwide.
Yeah, and part of the reason why we decided to do this podcast topic is, we're not trying to scare people and have them all run to their doctor saying, I think I have gastroparesis, but to just raise awareness. And there are factors that are overlapping, but just to be aware of what gastroparesis is, because we like to empower patients with more information and knowledge. And that brings me to my next question in terms of the risk factors. Now, you already mentioned one could be diabetes, but what are some of the other risk factors that would set someone up for possibly having gastroparesis?
Other common causes of gastroparesis that we know about are surgery, so esophageal, gastric, or duodenal surgery. So that goes into the category of post-surgical gastroparesis. Prior infection, so gastroenteritis, could then resolve and then develop gastroparesis. So very similar to post-infectious irritable bowel syndrome, which is more commonly known. Medications. So there are lots of medications that slow gastric emptying, and not necessarily causing gastroparesis, but it can cause symptoms of gastroparesis.
Yeah, I like that differentiation. We talked to a patient a few months ago who actually had an eating disorder and was working with a dietitian, and she was diagnosed with gastroparesis. But once they got her eating disorder under control, the motility in her stomach improved because the muscles was being used. So again, we don't want to scare patients, but we just want to raise awareness as to possibilities when they're talking with their doctor. Now, I'm really excited. I think, if we didn't miss anything about gastroparesis, kind of laying the groundwork, I want to get into the guideline and what this means for diagnosis of gastroparesis, management, and also treating gastroparesis. What are the options for patients? So let's start with some of the highlights, Dr. Camilleri. What are the highlights on the areas of risk factors, diagnostic testing, and we'll start from there.
Well, I think among the risk factors, the one that we focused on, because that's where there was the evidence, was the fact that if people have poor control of the diabetes, they are more likely to develop gastroparesis. So among people with diabetes, really strict diabetic control, better blood glucose control is going to be one of the factors that could be very important to prevent the development of gastroparesis. So that's among the risk factors, that's the one that was identified. In terms of the diagnosis, we examined very thoroughly the various methods that are available to try to find out how the stomach muscles, how the stomach is emptying. And we concluded that really the two main tests that are helpful in clinical practice, which are non-invasive tests, are to use a radio-labeled meal and a gamma camera, so-called scintigraphy. That's what the doctor might say to the patient.
Okay.
We're going to do a scintigraphic stomach emptying test. What does this mean? This means taking something like a scrambled egg and putting a small amount of radioactivity in it, eating the scrambled egg, often with a piece of toast and a glass of skimmed milk, and then pictures are taken of the stomach, of the abdomen, with the patient standing, and they're taken immediately after ingesting the meal, and then 1, 2, 3, and 4 hours later. And it's a very simple, non-invasive test with very low radiation exposure. Now, what's really important is that it's been shown in the past that you have to do this test for at least 3 hours, and preferably 4 hours, to get the most important information, which is how much of the food is remaining in the stomach at those time points. Okay, and that will also help guide the treatment. The second type of test that's also approved by the FDA is based on a breath test, where a substance called a stable isotope, which is not radioactive, is incorporated in the meal. That could be a scrambled egg meal, it could be a muffin. And then the patient exhales their breath into a tube, and that is collected at defined time points over 4 hours. And then it's sent to a centralized laboratory where the carbon dioxide in the breath is analyzed to see how much of that stable isotope that was derived from the meal and has been metabolized in the body is excreted, is exhaled into the breath. And by doing that, it's possible to get an estimate of the rate of stomach emptying. So those are the two main tests that the guideline concludes have the greatest evidence of their accuracy.
Now, what would determine whether a patient would take scintigraphy or they would take a breath test? Is there one preferable or the other? Is one easier? Do you have to go to the office for both of them, or how does that work?
Well, the availability of gamma camera is obviously important, because you can't do the scintigraphy test without the gamma camera. So very often that's one of the determining factors. The second is whether the office of the doctor has actually incorporated that breath test method into their practice. So the only way I can answer that, and maybe Dr. Nguyen has other comments on this, is it really depends upon local availability of the test. But at least we know that those are the two most robust tests for stomach emptying. And we make the point that doing other types of tests, like an X-ray of the stomach after ingesting like little rubber rings, if you wish, like that's not going to be a very accurate test, even though it could be easily available.
So
yeah,
the point,
I think part of it is definitely availability. So I think scintigraphy is the most widely available, but I think what's most important for patients to know before getting a scintigraphy is ensuring that it's an adequately done test. Doing a test where it's liquid only, or they're eating oatmeal or bananas or some other made up meal, just it is an invalid test. So even though the radiation exposure is minimal, it's really a waste of time, energy, and cost. So you have to use a standardized meal, or be like the Mayo Clinic and standardize your own meal so that you can do a comparison. But you can't do just random meals. So that's like, I think that's the most important part of getting a scintigraphy, is making sure it's a good test. The other test I think that was mentioned in the guidelines is the use of wireless capsule motility study in patients who have kind of, extra gastric symptoms. in our group, we retrospectively looked at patients with delayed gastric emptying and found that about 60% had slow transit constipation. And there have been other studies that have found that patients who are presenting with gastroparesis-like symptoms will have delayed small bowel and or colonic motility. So it's, even though we say gastroparesis, there could be dysmotility outside of the stomach. So in individuals who have symptoms that are beyond the stomach, then consider doing a wireless capsule motility or a whole gut scintigraphy, where you're doing the scintigraphy that Dr. Camilleri described, but it's extended to look at the small bowel and the colon.
And that's great information for patients that may, again, I love that you keep going back to the symptoms. And again, we're not saying that the symptoms are gastroparesis, but it's important to recognize that it could possibly be something else, but it's good to raise it with your doctor and to be aware of other things that it could be presenting as gastroparesis, but may not be it.
And I think the reason that we keep going back to the symptoms is because we don't have a cure for gastroparesis. So when we get into the discussion about treatment, we're treating the symptoms. So it's more important, I think, to focus on the symptoms and what's troubling the patients, as opposed to really, yes, the diagnosis is important, but I think the gastric emptying test, it can vary over time. And so then what happens when one's normal, the second one is abnormal? Do they have gastroparesis or not? But in the end, you treat the symptoms.
So, I want to make a point to really help patients understand guidelines are based on evidence, and you look at all the studies and you come up with best recommendations, but it doesn't mean it's the be all end all, right? There could be other things that maybe there's not a lot of research yet. Like if you look back how many, maybe 5-10 years, the low FODMAP diet, there wasn't a lot of evidence out there to put it in a guideline as, highly recommended, but there was very successful cases where patients, were helped by a low FODMAP diet, and now the science has evolved. So can you explain a little bit what that means? Like, even though there may be a lot of evidence and the recommendation is high, there may not be a lot of evidence, but it's still, maybe a good treatment or option, but why you should know this so that you can talk to your doctor about this is what I'm getting at.
Yeah, I mean, number one, the challenge with writing a gastroparesis guideline based on high quality evidence is that a lot of it is really lacking. The only FDA approved medical therapy for gastroparesis is metoclopramide. I'm older than metoclopramide, but not by that much in terms of when it was first FDA approved. So you have to take that with a grain of salt in terms of how you apply the guidelines into your clinical practice, that we're not paralyzed by the lack of evidence, and look at sort of, best practices and think about symptoms and sort of mechanism of action of the agents.
So, let me build upon that, if I may, because one of the things that we specified in the guideline is that our recommendations are limited by exactly what Dr. Nguyen has said, and that is that the only medication that's currently approved for the indication of gastroparesis is metoclopramide. Oh, and incidentally, you can only prescribe it for 3 months, as though your patient's symptoms are going to disappear in 3 months. So we have to go back to first principles, as Dr. Nguyen says, to consider what are the symptoms, how can we help the patient? And that's why some of the other recommendations in the guideline specify principles. So, for example, we have a recommendation that says, in general, the class of medications that we call prokinetics that stimulate the stomach are better than no treatment at all. Now, we can't say they're better than X because there is no comparison with X. But right. we believe, because of an understanding of the pathophysiology and not full clinical trials, but sometimes proof of concept studies, that a prokinetic approach can improve the function of the stomach, and that should be associated with improvement in patient response outcomes or symptoms. And so I think it's important to keep in mind that very often we doctors have to apply basic principles, go after the symptoms that are hurting the patient, and come up with the best combination of prokinetic, antiemetic medications. And then we projected what might be future treatments. And so even though they don't come in as recommendations at the present time, there are a number of parts of the guideline document that have extensively reviewed the potential of new treatments, whether it's ghrelin receptor agonists or an area which Dr. Nguyen is an expert in, electrical treatments, vagal nerve stimulation in the neck, which are very, very promising, of things that we hope by the next guideline will be established in the literature. And I want to make one final point. There's one very well conducted randomized controlled trial on small particle diets in the treatment of gastroparesis. That came out within the last 10 years. But I can assure you that doctors looking after patients with gastroparesis have been telling them to homogenize or blenderize their diet for more than 30 or 40 years. So even though we didn't have the evidence from the randomized controlled trial, it made most sense to help the patients to be able to tolerate and ingest their food and get the nutritional and hydration benefit from that food by putting the particle size in a smaller size so that food can empty more easily from the stomach.
That's a great example. You said that so much more elegantly than my question was, which was, even though it's not in the guideline, it still could be a way of helping patients. So we want to empower patients with that knowledge, like, don't freak out, don't get worried. We always try to be positive. There are, just work with your doctor to find the best course of treatment and options for you. So we want to educate you about the guideline, but we don't want to put you in this little box where you only can follow along with just this way. And you gave a great example, Dr. Camilleri, of that small particle diet being available all that time. So thank you.
I mean, I think the most exciting part about the guidelines is sort of outside the guidelines in terms of the list of different therapies that have been looked at and the data. And they're all, majority of them are open label pilot, but they show promise about different therapies that could potentially show up in the next guidelines. So for me, that was the most exciting part about working on this guideline, and what was sort of the hope for the future.
No, and I love that you said hope for the future, because we talk to a lot of patients and we see the gastroparesis patients and the advocates really struggling, and it's heartbreaking at times hearing their stories. So when we bring on experts like you and Dr. Camilleri, that can really showcase what's happening in moving in a forward direction, that there is hope and that there's still research going on, correct, doctors? There's still research going on to help patients. And maybe they're not in the guideline now, but they could be coming down the pipeline. That's good news. Would you say so?
Yeah, I mean, another example has been the way in which GPOEM, the gastric per-oral endoscopic myotomy, has evolved. So over the last 10 years, we've been seeing these open-labeled studies that suggest that if the laparoscopic surgeon or the endoscopist actually opens up the lower end of the stomach, the pylorus, the valve at the lower end of the stomach, then there could be an improvement in stomach emptying and also in the symptoms. And we always were worried that these were all open-labeled studies. But really, almost at the tail end of our work on the guideline, suddenly the first pilot randomized controlled trial, which compared the endoscopic pyloromyotomy with a sham procedure, becomes available. Literally, it became available in April this year as a first abstract, and we were able to incorporate it. And we were able to say, okay, all of that open label information was questioned whether it was actually going to pan out. But from this first truly controlled study, we now have evidence that, in fact, it is very promising. And, further studies will need to be done. But the first randomized controlled trial is very promising. And it illustrates the point that Dr. Nguyen also made, and that is that there is hope. There is continuing research that's being done to come up with therapeutic approaches to help patients.
Do you remember, I don't know, it was a few years ago, Dr. Lacey wrote a paper in the American Journal of Gastroenterology that called for researchers to really expand their view of how they approach gastroparesis studies. All right, and I don't remember all the details offhand, but it was basically like look beyond what they were already looking at, expand that the causes could be other things, and to expand the study's framework accordingly. Are you seeing a shift in how studies are going in gastroparesis, that they're looking at other things, not just the same, just diabetic gastroparesis? They're looking at other things.
I think this is a moving target, because gastroparesis is quite heterogeneous, right? In addition to the delayed gastric emptying, we have impaired gastric accommodation or relaxation of the stomach, visceral hypersensitivity or decreased sensation. And we sort of throw all the patients together in the same gastroparesis bucket with delayed emptying when we recruit for clinical trials. Yeah. So the big question is, should we be looking at nausea, vomiting predominant, early satiety predominant, discomfort or pain predominant, kind of similar to irritable bowel syndrome. We don't look at IBS diarrhea and IBS constipation in the same, clinical trial. So perhaps some of the challenges that we are seeing in trials kind of crossing over into that phase 3 FDA approval may have to do with the heterogeneity. There is also a very high placebo response rate. And I remember during my fellowship thinking, why would there be such a high placebo response rate in patients who have failed everything? Like, you've tried everything and they haven't gotten better, but all of a sudden they're in a clinical trial and there was a high placebo response rate, and in some studies up to 40%. Oh, wow. And that's the part that I've never been able to answer. I don't know, Dr. Camilleri, your thoughts on the high placebo rate.
Well, I remember two things. One is that there was a very famous editorial written by a famous doctor called Dr. Harold Kahn, who said that it was about upper GI bleeding. And he said, if I ever had an upper GI bleed, I would like to be enrolled in this study and I would like to receive placebo. So it isn't just gastroparesis that is associated. The other thing I'll remind myself is that when I was a fellow and I did my first clinical trial of a medication called cisapride for gastroparesis, and I'd done all the study, and my mentor, Dr. Mala Jalada, who was a wonderful expert in gastroparesis, at the end of the study, when all of the data were unblinded and the analysis came through, he came to me, and I was the fellow, and he said, "I'm afraid the study was negative." And he said, "You were too nice to the patient." And that's why the placebo response was too high. You have to be, of course, nice to your patients. And that's one of the reasons why we are in medicine, right? But I think we still don't understand. But I want to take us back to a more general point. And that is that I am so enthused by the variety of options that are being tested in the context of gastroparesis. I mentioned the vagal nerve stimulation in the neck, which Dr. Nguyen and her group are working on. We are very fortunate to be studying with help from the National Institute of Health, a cannabidiol, which is a cannabinoid type 2 receptor agonist, which affects the cannabinoid receptors in the stomach and in the intestines, not in the brain. So it doesn't have any of those psychological or other effects. And so, pharmacologically, and also with devices, as well as with the endoscopy approaches, and I've only mentioned one pharmacological approach. There are others that are being studied. I'm optimistic that in time we will have better approaches to treat patients. And of course, this takes time. And the process of getting medications approved or devices approved by the FDA takes time and effort. But there's a lot of interest among physicians like Dr. Nguyen and myself and others to try to help patients in this area of practice.
Well, that's such great news. And I know the patients who are listening are going to really appreciate that. This is really positive news. Now, if we go back to the guidelines a little bit, you talked about the pharmacological, option, but what about the non-pharmacological therapies? Like, I think in the guideline, it was mentioned acupuncture, herbal medicines. Is there anything else that patients should be aware of and talk to their doctor about? We don't want you to just kind of start going on your own and just start doing things. Listen to what Dr. Nguyen and Dr. Camilleri advise here, but we do want to point it out.
There's promise in terms of herbal therapies, but the trials are really not definitive in terms of its efficacy in gastroparesis. And really the data extrapolates mostly from functional dyspepsia. And so the herbal therapies for the stomach seem to be more effective for functional dyspepsia than gastroparesis per se. So you have to be careful with herbal therapies. I think acupuncture, on the other hand, especially combining acupuncture with prokinetics, seems to be beneficial in terms of accelerating gastric emptying and improving symptoms. The challenge is in terms of going out to get acupuncture. What do you tell the acupuncturist? So you do have heterogeneity in what acupuncturists will do or which acupoints.
That makes sense. So in terms of the guideline, there was no definitive recommendation for anything in that area, correct?
That is correct.
No, that's great. So is there anything else that patients need to know about the guidelines? Anything that they need to discuss with their provider at this point? What are your tips for patients listening in today?
So I have a couple of things that I would think patients should be asking. So
I love this.
What questions should patients ask their physicians about their care? And I think the questions that patients should ask are, is my stomach emptying test normal? Okay. And second, based on my nutritional state, what would be your recommendation for my diet? What would be your recommendation for any medications that I should receive? So I think those are important. And then the other thing that I emphasize with all my patients is to remember, yes, gastroparesis, the stomach has an important role, and that is that it helps us put nutrients and fluids into our intestine to maintain our nutritional state. So don't forget, and this is what I always emphasize with patients, don't forget that the objective is to make sure that you are replenished well with nutrition and with fluids and your electrolytes. So those are the kind of the three things that I would like patients to remember to, pose questions to their doctors.
Well, that's great advice. Dr. Nguyen, anything from you want to add on to what Dr. Camilleri said?
I always start with what are your goals? Like, why did you come to see me today? And the reason I ask that is that there are some patients who have symptoms and the symptoms are mild, but they just want to know what's the cause of their symptoms and not necessarily have, discuss treatment. Or there are patients who are completely debilitated by the nausea, vomiting, but the nausea is the more predominant symptom. That's the one that really impacts their quality of life, and they want the nausea under control. The bloating's there, but it's not as severe. So what are your goals in terms of just kind of general goals? And then what are your goals in terms of which symptoms have the greatest impact on impairing your quality of life, your nutrition? The one question I think I've been asked by others, and I don't know if this is something that we want to debate here, is that, in the figure, we include pyloric injection of botulinum toxin, But in our guidelines, we recommend against that. And unless you go in and read, the fine print, it does cause some confusion there.
Oh, no, thank you. I didn't realize that. Wow. Okay.
Well, the reason why there was that confusion is that if you look at the totality of the information, our great specialists appraised the botulinum toxin injection as being something that isn't evidence-based. But again, what happened in the last year was that a very large study from France actually showed that if you measure how that pylorus is working and you measure its distensibility and its diameter, it was shown that the botulinum toxin injection significantly improved the refractory vomiting of the patients in that study. And it was a large study of more than 150 people. And so this is one of the dilemmas that you have when you write a guideline. There's something that gives you hope, like if you applied the botulinum toxin injection in the context of the patient whose pylorus does not distend well, there was evidence that botulinum toxin injection would work. However, if you take the totality of the evidence, and there are probably 10 open label studies and 2 randomized controlled trials, it wasn't something that the appraisers of the randomized controlled trials would suggest that should be included as a positive recommendation, because those 2 trials, one of which was from Philadelphia, the other one's from Leuven in Belgium, both came to the same conclusion. In randomized controlled trial, botulinum toxin was not efficacious compared to a placebo injection. So this is where it's dynamic.
Yeah.
The evidence is coming out. And so we wanted to make sure that we were able to provide all of that information.
And for patients, this is perfect evidence that there's no one size fits all approach. You're unique in your journey, your health journey. And this is why we keep saying this over and over again. You can be empowered with this information, but it's so recommended that you speak with your doctor about your situation and what's going to work for you, and not what you've read on the internet or even heard in this podcast. It's about what is good for you based on what you and your doctor decide together.
The botulinum toxin question was a perfect example of how therapies, guidelines evolve based on new evidence, but also I think as we think about categorizing patients, not just based on symptom subtype, but pathophysiologic abnormalities, then you can guide therapies based on that. So not all patients with gastroparesis have a pyloric function, but if you can identify those with pyloric dysfunction, then the botulinum toxin is the appropriate therapy. But again, if you take the whole group, it's not the appropriate therapy. So as we fine tune the kind of pathophysiology of gastroparesis and then direct the therapies towards that, we may find that patients can be subcategories and respond to therapies that in the past, the trials were negative.
Well, thank you both so much. And I really appreciate you both for being on today. And thank you all to our listeners for tuning into another episode of the Gastro Girl podcast, this one in collaboration with ACG's Patient Care Committee. Don't forget to rate, review us, and subscribe to us on your favorite podcasting app. And also this video podcast is available with others on YouTube. So thank you very much.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.